Good day, everyone. You are tuning into a webinar that's being convened by the Coalition for Global Hepatitis Elimination and the INHSU Prisons interest group. We're going to be looking at the ways to expand access to hepatitis C virus prevention, testing, and treatment in prisons. Recommendations coming from a workshop that was held at the last INHSU conference in Glasgow, Scotland in the fall of last year. Next slide, please. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination. I'll be co-moderating this webinar. Just a few housekeeping items as we get rolling here. Really want this to be interactive. So as you hear the discussion virtually, please join in with comments and questions submitted to the Q&A. The webinar will be recorded and posted on the Coalition website at globalhep.org, as well as on the INHSU website for future viewing. We ask you to go to our website for more information and to sign up for our monthly newsletter so you can stay abreast of all the developments in hepatitis elimination, as well as do the same for the INHSU newsletter for their various projects and activities. Next slide, please. As I've already mentioned, I'm John Ward. I'm joined by my colleague Andrew Lloyd from the Kirby Institute in Sydney, Australia. You'll be hearing from him in just a moment. Next slide, please. For those of you who are not familiar with the Coalition, we are part of the Task Force for Global Health in Atlanta, Georgia. Started about 40 years ago by former directors of the US CDC to work on a variety of global health initiatives, including taking on management of a variety of disease elimination programs. And for that reason, in 2019, I moved officially over from the US CDC to start the Coalition for Global Hepatitis Elimination to help form a community of practice, such as the one today, to look at various ways of improving access to the critical services needed to achieve goals for hepatitis elimination, and thereby strengthening the evidence base for programs to get started and operate and successfully achieve goals for hepatitis elimination. And then through all of that, seeking to bring new stakeholders to our collective efforts of achieving goals for hepatitis elimination. Most recently, in that regard, we successfully promoted the launch of a UN group of friends to eliminate hepatitis, bringing together about 35 countries with stated commitments to work within the UN system to build capacity for hepatitis elimination. We're very excited to be part of this webinar, which is the outgrowth, as I mentioned, of the workshop and of a report coming from the workshop that you'll be hearing about in just a moment. Next slide. I'll then turn it over to Andrew to give you more information about the INHSU and the INHSU Prisons work group. Andrew?
Thanks so much, John. So as has already been flagged, I'm here representing INHSU and INHSU Prisons in particular. And INHSU is an international network on health and hepatitis in substance users. And within that broader endeavour, there is a network called INHSU Prisons, which is a special interest group for folks who are interested in working in advocating for the prison sector, in particular in relation to hepatitis C care in custodial settings, so hepatitis C care for people who are in prison. The broader focus of INHSU is on the broader health issues associated with people who are in prison, including other infectious diseases and harms that occur from drug use. Next slide. So I'm going to start just with a couple of slides to set the scene for the webinar today, and in particular to focus your attention on the fact, the big ticket fact that the prisons are indeed a focus of the burden of disease of hepatitis C globally. And following on from that, a focus for our attention with a view to national and global elimination efforts. I've got in this table here a summary of some reviews of the prevalence of hepatitis C among people who are incarcerated. And as a broad statement, you can see that we would conclude that the prevalence in the incarcerated population is very much higher than the general population, with the antibody prevalence generally sitting in the 15 to 25% range, and accordingly, the chronic hep C prevalence being about a half or 2/3 of that rate. And that reflects the fact that it's people who inject drugs that are indeed one of the premier risk groups for hepatitis C infection and are heavily incarcerated. Next slide, Lindsay. So that, given that burden of disease, what follows from that would be to ask and answer the question across the globe: how good is our coverage, we might call it, of hepatitis C testing and thence engagement with care and engagement with treatment? This is data from presented at our workshop actually by Sharon Hutchinson, which comes from the European setting. And I think if I was to give you a global perspective on these data, it would be reasonable to say that we could and should expect that Europe should really be a leader in the uptake, provision and uptake of testing and treatment. But you can see that there are some exceptions. There are some countries that are doing pretty well with good coverage of both testing and treatment, but they are indeed represent a small minority of countries. And this is what you might call a best case scenario for the developed world. Less good in North America in general, perhaps slightly better in Australia, but across the rest of the globe, less good still in terms of testing and treatment coverage. So we have plenty of work to do, hence our interest in advocating for policy and practice change in this sector. Next slide. So there it is. That's our problem. We have a large burden of disease, insufficient testing and treatment service provision. And so the task for today is to consider that problem and how we might go about generating solutions to that problem to ensure equitable access to prevention, to testing and to treatment. And the premier argument for this approach is that because the prisons carry such a large burden of disease, it's a key venue for elimination efforts worldwide, in addition to being an access and rights issue for those who are incarcerated. Next slide. So we did indeed hold a workshop, as John flagged, late last year in Glasgow in Scotland, which was a very productive and interactive workshop with about 60 participants. And a little bit like we've just done in a way, we covered some of that latest epidemiology, some perspectives on the policy and the practice and models of care in the prison setting, and then had a discussion about advocacy needs and potential solutions in the interactive format for the workshop. And all of that has been synthesized. Next slide, please, Lindsay. All of that's been synthesized in a report that I'd very much encourage you to read, which is illustrated in this graphic here, which highlight and is downloadable with the QR code that you can see here and the image. So this report highlights a whole series, I think of the order of 20 recommendations that arose from that workshop, which I'm sure we're going to touch on to in some of the discussions with our panels today about policy change that might need to happen, about practice change, about models of care. So I'd strongly recommend you to have a read of that report. Next slide, Lindsay. So moving on then to our format for our meeting today, we have chosen to enrich our program with two panels. So starting for the first half of the webinar with what we call panel one, who's going to focus on policy and financing, roadblocks and solutions. and then panel 2, who's going to focus on models of care for testing and treatment in the prison setting. John and I are going to moderate the first panel, and Nadine Cronfley and Matt Akiyama the second panel. You can see the names of our panelists there, and in a moment, when we start the first panel, I'll be asking each of them to briefly introduce themselves to you. Next slide, please. So moving straight on then to our first panel and our panelists. I'm going to go clockwise from top. So Luke, would you mind saying hello and introducing yourself?
Yeah, good morning, everyone, or good evening, wherever you are in the world. My name is Luke Grant. I'm the Deputy Commissioner for Corrective Services in New South Wales. So I've been working in the prison system for about 35 years, both in the custodial space and also in the community correction space. And I've been actively interested in this area for some time, and I've been collaborating with Andrew and others on some of the strategies we've put in place to try to eliminate hepatitis C in our prisons.
Thanks so much, Luke. Nonso?
Thank you, Andrew. My name is Nonso Madoka. I work with Bernster Development Foundation. I'm also a member of the INHSU Prison Executive Committee. I've been working within the prison for over 10 years, doing interventions as a community activist. I'm based in Nigeria.
Thanks so much, Nonso. That was it. Yep. Antons.
Hello, everyone. My name is Antons Mozalewskis, and I'm currently the technical officer for key populations at the WHO headquarters and the Global HIV, Hepatitis and STI program, working with Annette Verster and Niklas Luhmann, whom you might know. And previously, I was working as the hepatitis regional advisor in WHO regional office for Europe for 7 years. So I was working closely with many programs in Eastern Europe and also Central and Western Europe. So yeah, I'm happy to be here. Over.
Thanks so much, Antons. And Catherine?
I'm Catherine Barth. I'm with the Louisiana Department of Corrections and LDH. I'm the document manager for the hepatitis C program. I collect all the information labs and such. I've been doing that for 3 years now. So we're just continuing to add our information as we go.
Thanks so much, Catherine. Jean?
Hi, I'm Jean Scheck-Snyder. I'm the Corrections Coordinator with the Louisiana Office of Public Health, STD, HIV, Hepatitis C program. I've been working with SHIP for about 15 years exclusively in the Louisiana Department of Corrections. For the past 3-4 years now, my focus has been on the HCV screenings that are happening.
Thanks so much, Jean. And Anthony?
Yeah, so my name is Anthony James. I'm the Deputy Director of Programs for the Louisiana Office of Public Health, STD, HIV, Viral Hepatitis Program. I've been with the program now for 10 years. For the past 3 years, I've been serving as the Deputy Director of Programs, specifically overseeing our state's viral hepatitis elimination strategy.
Thanks so much, Anthony. And last but not least, Risha.
Hi, I'm Risha Urban. I'm an associate professor at Johns Hopkins in Baltimore, Maryland, where my focus is really on hepatitis C elimination. I've had the pleasure to collaborate with colleagues and Department of Corrections here in Maryland, in Delaware and Rhode Island. And then since 2018, I've had the pleasure to work with Louisiana on some of the research aspects of their hepatitis C elimination project.
Fantastic. Thanks so much, everybody. So let's get into some discussion. I think we might start, if it's okay, with a global perspective, which I think Antons is probably best placed to provide us with. So Antons, I wonder, given that backdrop about the burden of disease that I briefly presented, what do you think are the key policy gaps globally that relate to this sector, and what opportunities have we got to perhaps try and fix some of those policy gaps?
Thanks for the question, Andrew. So let me start maybe with the statement that actually, first of all, we don't have much data about the coverage of services, because even at WHO, we don't really have a special prison program. So we have some activities within the HIV and hepatitis program, but there is no such a prison program, except the European region. There is the European prison health program, which collects the data from member states. So in Europe, we have more or less decent data about health systems in prisons and about also service coverage in prisons. So that's maybe where we have the information from. So about the barriers, they are very well described in the report, which I welcome everyone to read. It's really good. But from my perspective, I think one of the kind of the basis problems and barriers is maybe poor public and political support for prison health in general. So it's not only about viral hepatitis, but also other health services. So despite that, we know that there's Mandela principles which say that everybody have to have a similar access to the same standards, both in the community and the prison. I think in most countries is not the case. So that I think is the ground of the problem. Then of course there are budget limitations. And one thing which was not mentioned in the report, I think it's important to note that in many countries, prison health is not directly linked to the community health. So it's not under Ministry of Health, so it's either Ministry of Justice or other ministry. And so there is less accountability maybe, and less link between the community and the prison, and maybe we as WHO have less access to those services. As for policy gaps and implementation gaps, we all know that there is a lack of services, and partly because there is lack of recommendations until very recently. We know viral hepatitis, the area which is developing really fast. And even when I was starting with working on viral hepatitis 7 years ago, that was really something really complicated and was available only in tertiary services. But now we know that the hepatitis C particularly can be treated by really even by nurses, and I think one of the opportunity is to decentralize and to do the task shifting, but probably we will talk about this in the second panel. The other opportunities is to build on the existing programs. So if there are HIV programs in many countries, the HIV programs, and we have seen that these HIV programs, they are also able to address hepatitis C and also hepatitis B. There is also opportunity for funding through the Global Fund. Now you know that the new Global Fund policy says that they can support testing and treatment of hepatitis C, not only for co-infected people, but also for key populations if it's delivered on the basis of HIV programs. So there are many opportunities, and I'm quite optimistic actually, and we have seen so rapid progress in scaling up the hepatitis services, and I think the elimination in prisons is kind of a low-hanging fruit. So I'm really sure that we have all the tools and all the possibilities to change this situation. Maybe over from me for now. And
thanks so much, Anton. It's a great broad brush perspective. I wonder if we might stay on the same topic and just invite perspectives at a more national level from maybe Nonso and Risha would maybe to talk about the policy landscape in your country with regard to hepatitis services in the prisons. Nonso, would you like to start?
Okay, thank you, Andrew. Yeah, like I said, I work in Nigeria, and first the workshop, the reports is wonderful. It's very rich, and everything listed there as a barrier, policy-wise, is fact. It's applicable to Nigeria. However, just like Anton said, the two major things for me is health governance in prison, and then the criminalization of drug use. What I mean by health governance in prison, here in Nigeria, the prison is under the Ministry of Interior. The health is not under the health governance is not under the Ministry of Health. It's basically under the prison, and you can say under the Ministry of Interior. Now, the challenge is the priority of the prison. Their first priority is custody and security. Their second priority is access to justice, ensuring that the inmates are taken to court when they have court dates. And then the third one comes to the duty of care. And when you come to that duty of care, you find out that they prioritize feeding first, and then providing issues like water. Now, if you go by this priority, you will understand why having health issues being under prison authority is a big problem. It's a massive problem. And for me, I wish that that discussion should be started, not just in Nigeria, but in sub-Saharan Africa, because that seems to be what is obtainable in almost all the countries in sub-Saharan Africa. Because for the inmates, because of the health being under the prison authority, it affects the health budget, it affects the staffing. It's quite difficult to integrate prison health with the public health or the general community health. It's difficult to have the independency of practice by even the health professionals. They are actually they submit to whoever is the officer in charge or the controller of a state prison. And so it becomes a very big problem, very big problem. So that's one, health governance.
And so, yeah, I was just going to say, so in practice in Nigeria, that health governance issue, do you think that, or tell me, does that lead to a lack of services? What are the hepatitis services in the Nigerian prisons?
There's no service per se. There's no structured government-led service in Nigeria. We don't even have a data of hepatitis prevalence, either anti-HCV nor even chronic hepatitis in Nigeria. We don't have a data. We really don't know what is on with viral hepatitis C in Nigeria. So nothing is happening with regards to viral hepatitis C within our prisons.
Okay, so we've got some varied perspectives on how much service delivery there is from across the globe. Risha, can you say something about the US policy and practice landscape for prison hepatitis services?
Sure. I would say, in the US, what we've seen, over kind of the last decade is that we've had really limited hepatitis C testing and treatment in corrections. If you talk to most of the wardens and kind of others over even kind of jail systems as well, kind of the local facilities, it's often related to the cost. And with the expected prevalence that we would see across prisons, that those things would break the correctional medical system's kind of budget in terms of financing. And so that's been kind of the limitation to test, because if you're not going to be able to offer people treatment. In the places where treatment has occurred, even most of those have had restrictions around who could be treated. And most of them were testing around medical indications, not offering general testing, but there would be medical indications. And then oftentimes you had to have a certain fibrosis level, such as F2 or above, to be able to access treatment. The other issues that many of our systems have had is just in terms of having providers that were comfortable with treating hepatitis C as well. And so that's also been a restriction. Louisiana is going to talk about their program later and how they've been able to overcome many of these barriers in terms of access to drug with their drug deal, in terms of getting access to kind of drug for everyone and being able to treat more people, but also using things like treating people in cohorts, using telemedicine. And so I think they really serve as a way we can expand care and corrections across the U.S.
Thanks so much, Risha. I've gained a great overview of a list of barriers and maybe some potential solutions. I think one thing I wouldn't mind to pick up on, I think Nonso flagged, and move over to you, Luke, is that kind of separation of the powers issue. That is, the correctional service and the health service are different authorities. Do you see that as a kind of a surmountable barrier, so to speak? What's the experience from Australia?
Yeah, so we've had that situation for decades now, where the health provision is provided by a statutory health corporation in the same way as health provided across our state. So we do have universal health coverage in Australia, and in prisons we have adopted the premise that there should be equivalence of care, and we've had a very separate organisation responsible for the delivery of healthcare to prisoners. And going back to the HIV sort of period, immunologists and infectious diseases specialists have had a really big role to play in that organisation. So we've got a body of expertise and a great interest in managing hepatitis or other bloodborne viruses. I suppose what is still the case, however, is that corrective services is still the primary organisation with full control over access to prisons and the routine that happens in jail. So if you spoke to our health providers, they'd probably be complaining about some of the access problems they have and that we don't make health our highest priority. So having a separate health agency and corrections agency doesn't resolve all those problems. And we have different statutory frameworks and different objectives. So whilst the social determinants of health and the social determinants of reoffending are very much the same, in pursuing these objectives as an organisation, we're a law enforcement organisation. So we have prohibitions on the use of syringes, for instance, in jails, and offences against that on the one hand. On the other hand, we've got a pretty well-established supply, harm and demand reduction strategy in place. So there's some curious tensions there sometimes between what's appropriate and what isn't. And the only other thing to comment on, hearing about the burden of disease and the risks of prisons, I think prisons, we should flip that and look at prisons as a great opportunity for health intervention for people who often live in chaotic lives. When they're in that environment, it's this ideal opportunity to treat. And in this state, where we do have a really big program using direct acting antivirals, about 40% of the whole state's usage of those drugs is actually in prisons in this state. So just to give you an indication that prisons do provide this enormous opportunity for intervention. And you need to put that in the context of the number of people. We've only got 12, I don't know how many people in our state now, Andrew will probably know, but maybe 7 or 8 million people, something like that in New South Wales. But we've got about 12,000 people in prison, of which about half of them are regular and frequent drug users in the community, and a subset of that are intravenous drug users. So we're talking about quite a small population are responsible for about 40% of the effort in terms of treatment, which I think is pretty amazing. And so it's a great opportunity. The only other comment I'd like to make, and I have seen in a lot of papers, including some of yours, Andrew, which is about the criminalisation of drug use. And in fact, in our prisons at the moment, we don't have a single person in jail whose most serious offence is a drug use offence. And we only have 12 people out of 12,000 who have a possession charge. So in the state, the police do actually do have an approach which is reasonable in relation to drug use. It's the offences that are associated with drug use that are being prosecuted in the state that bring people into jail, not just use and possession charges, which effectively been eliminated. So as I say, 12 people across the whole of our population have those offences as the reason they're in jail.
Thank you, Luke. That really shows the positive attributes of the program in Australia. I wanted to get the Louisiana contingent involved in the conversation here. I wanted to first move over to Anthony, and you have a HCV program going on in the Louisiana correctional system. We're focusing on the policy development. What were the policy knobs and levers that were turned and pulled to bring together a program? What were the critical elements that led to the launch of Hep C test and treat program in Louisiana. Anthony.
Yeah, so I'll probably say that context is important in this conversation. And so I think it's important that I provide a little bit of background in terms of our relationship working with the Louisiana Department of Corrections. The Department of Corrections is a separate state entity within Louisiana, similar to the Louisiana Department of Health. So we have different charges, different functions in which we have to, carry out in terms of meeting our mission and our charge. That said, that's not to mean that there has not been collaboration between our departments. In fact, we've been working within the Louisiana Department of Corrections, for several decades now. First, leveraging our resources as it relates to dealing with persons who are about to be discharged, say 90 days prior to, and giving them, support, who are living with HIV, in order to ensure that they have access to medical services, support services, and things along that line. In doing so, we've also been able to expand our work with the Louisiana Department of Corrections, and that brings us to where we are now as it relates to our state strategy to eliminate viral hepatitis C. So in 2019, we launched a plan to eliminate viral hepatitis C within the state, and we focused in on two very specific populations. One being our Medicaid population, are those who are insured under the state's insurance system. That's also working in tandem with the federal government, but then also working with our Department of Corrections. And so what we were able to do is that, leveraging the work that we have done with the Department of Corrections in the past, providing medical discharge planning, but also offering testing for HIV upon intake and discharge, we were able to bring in viral hepatitis C as well as testing for hepatitis B into that fold as well. I think, when we talk about it from a policy standpoint, I think there's been some considerations that we have rationed care over the course of time because of, the exorbitant cost of these medications. And so one of the things that we did as part of our plan was to look at what we could do to eliminate some of that rationing of care. So that was eliminating fibrosis requirements. So you no longer had to have, either fibrosis 3 or 4 score in order to qualify for treatment. We said, regardless, if you test positive and we know that you're living with viral hepatitis C within our correction populations, we are going to grant you access to that treatment. We eliminated provider restrictions. So before, you had to be a hepatologist, or infectious disease doc. And now that we know that we've got medications that's very efficacious in terms of being able to treat and adequately cure folks, we were able to drill down on making sure that individuals had access to those medications. Then we also eliminated sobriety requirements as well. However, that's less of an issue within our Department of Corrections because they are operating in a very controlled environment in which there's an understanding that certain things don't happen while you're within these confined walls. But that said, eliminating those things help to increase the pipeline of treatment access for folks. I will say that it has required in looking at our overall state's plan to eliminate viral hepatitis C, there is a total of 6 strategies. One of those is looking at establishing an innovative payment model where we could gain access to a drug that we know works, that can cure people. It's very easy to take. There are very few and far in between side effects. Gaining access to that drug and then making it available, leveraging, within the system of the U.S., where we can get access like, 340B medication or can negotiate a particular price for a medication. Those are the directions that we were able to move into.
Thank you.
I'll also point out just, one other thing is that, while we are talking about the Department of Corrections within the state of Louisiana, we also have local, parish, county, or regional jails, that house a substantial number of Department of Corrections inmates. And so not only just looking at those who are housed within the state correctional system, but also those who are, living within our local facilities, making sure that those individuals have the same access and can receive the appropriate level of treatment. But I think, as Risha has pointed out, making sure that we have access to telemedicine, to where individuals may be able to, see a clinician, from where they are actually housed and have access to that. And then also making sure that we can, make the pipeline of medications available to them as we identify them.
Thank you very much. I know we're going to be getting into models of care in the second portion of this program, but I wanted to get Jean and Catherine involved. I know you're more, really heavily, immersed in the day-to-day operations of this, and perhaps relevant to this first question regarding policy. Just what's been the receptivity of implementing this within the correctional system? Were there any issues regarding provider training? Staff training, or even among the incarcerated persons themselves to raise awareness, deal with stigma, just to improve the environment to implement the program? Perhaps we could start there, please.
So for staff training, we have a nurse practitioner, Elizabeth Britton, and she has been able to provide really good training to the medical staff at each facility on treatment. We've been pretty successful at the state level, the parish level, where we're dealing with each individual parish has its own entity, is where we're running into more issues. But individuals who are diagnosed at parish are still see one provider through this program.
You have it.
Okay.
Well, that's really good to hear, and I think you raise a really important, issue, at least for the United States in particular. It's just the multiple jurisdictions that have incarceration in correctional facilities, and just having to deal with it on a federal level, state level, local level really adds to the complexity of this. But it looks like you're really tackling it by seeking to achieve equitable access both locally and at the state level.
And
Go ahead.
we have found before we go into a parish to screen, we will go in and we'll talk to the individuals and explain what the program is. And we always start by saying we are not DOC. We are Office of Public Health, who are working with Department of Corrections on this program. And we've gotten really good success once we're able to go in and explain the program and what we're doing.
Thank you. So Risha, I want to turn it over to you. I know one of your roles is to collect evaluation data and sort of monitor the implementation of the program. So I was curious as to, does that data have any role in maintaining the interest of the correctional system in this program, helping them see the benefits and sort of sustain this program until it achieves its goal for hepatitis elimination?
I think so. I think one of the great things about kind of Louisiana, that it's really been a partnership between the Louisiana Department of Health and then corrections, but then also having kind of our team from Hopkins kind of be a part of things and really talk about kind of the data. I think in terms of the data pieces that we're looking at, that I think will also just serve as a model nationally. Obviously, getting the initial prevalence data is important, but also looking at how many of individuals were missed or declined testing and factoring kind of that in. And then also going back in, obviously this is a public health implementation project, but using kind of research to go back in and sample to look at that decline in viremia to prove what's happening. Also, you can look at testing on intake and exit, and looking at the decline. You should be able to see that on intake as well because of the treatment that's going on in the community. And I would say the other piece that I think is going to be really helpful is the modeling aspect that we have as a part of this project. And in that, we're going to be looking at whether some of the observed reductions in HCV viremia among HCV antibody positive persons in corrections are consistent with what we would have expected with their intervention scale up. What's the likely interim impact from 2020 to 2024, and then looking at whether or not they'll meet the WHO incident and mortality elimination goals. And I think this will really help other states to kind of build out their programs. And as we're hoping to move towards a national hepatitis C elimination plan here in the US to use it as a model for what can happen in corrections, but obviously they also have data within Medicaid too. And I think those can help drive kind of a policy here.
Thank you. Just real quickly, one quick follow-up question. You mentioned you were working in Maryland, Rhode Island, and maybe 1 or 2 other states. And I was just wondering if you could do a quick compare and contrast of what's working well in Louisiana that could be a model for other states in the US or vice versa.
Sure. I would say, you know, Louisiana is kind of the best case scenario. In terms of some of the other work here in Maryland, we're doing some work with our local jail system to kind of increase hepatitis C testing and looking at some of our state facilities too. Also working with them on what happens kind of once people are released. We find that that's a very vulnerable population. And so we're kind of working on kind of metrics to get them. We have some different vans right as they leave that they can stop at and get tested and get substance use treatment as well. So that's kind of been the partnership here in Maryland that we've been working on. We had hoped in 2019, we hosted a conference here kind of on the Louisiana model, trying to move our state towards kind of a drug deal at the end of 2019. Then COVID hit and those things didn't come to fruition, but hopefully at some point we can move towards that. My partnerships in Delaware have been mainly around training providers to treat within their correctional system. And then in Rhode Island with Jody Rich and others there working with their programs in terms of treatment inside, but also looking at people on parole and probation as well. So some different types of work. I'll say one of the things we run into here in Maryland is that there's usually a contracted provider for medical care as well. And so there have been times that we've started work with one and then the state changes who they have the contract with, which makes it harder to kind of have consistent work as well.
Thank you. We touched on that all judicial system approach in Rhode Island. We're really seeking to have multiple touch points throughout the system. Andrew, you probably have some follow-up questions.
Yeah, I wonder if I could pick up on we've heard I think from Risha and actually think from Luke in Australia about different financing models, because if I've got it right, in the US the burden of funding the DAAs and I guess the service in general falls to the state and the Department of Corrective Services or the Department of Health. And I think Luke was describing in Australia that the healthcare system is socialized, and so there's universal access to testing and treatment for inmates. And I think Nonzo was saying there's nothing, so there's no finance, no service, no nothing. So Antons, maybe from you to start off with, in a global sense, what's to be done about financing models, to make recommendations or to push for innovative financing models?
Yeah, thanks for the question. I think there are 2 ways. One is if we look from the universal health coverage and this kind of view, then integrating prison health and community health could be helpful, because it kind of increases the if there is a procurement or if there is negotiation, it's easier to procure for a larger amount. So if the prison health is kind of included into the national health system, that's easier than if only the prison has to negotiate and has to procure the drugs. The other thing, the other perspective is, if we are looking at the donor funding, and I already mentioned, for example, the Global Fund opportunity at the moment. Actually, I see that somebody is mentioning that in Nigeria, there is no hepatitis program in the community and there's nothing to expand. Actually, it can be used as an opportunity. So prisons can be used as a pilot. Some countries in Central Asia, I was just recently been into Tajikistan, and there is no state hepatitis program, and there is almost no services. But within the Global Fund grants, they included the a pilot of testing and treatment in prisons, and that was covered also by the Global Fund, and I mean, they had a good experience in treatment, and then there's an opportunity for expansion after this. So yeah, I think it's a difficult question. But there are different ways, I would say.
And Nonso, staying in Nigeria, do you think there are opportunities in access, in provision of services linked to other existing programs, HIV or TB, for instance?
Yeah, there is, because I know there is an ongoing HIV program. Though there are gaps, but for me, what we really need to do in Nigeria to get hepatitis program in the prison is basically, number one, is to first of all have to get a surveillance of the data of what we have, the incidents in the prison. That's number one, and then we can take it from there. The issue of inability to integrate the prison health into the community health is one major issue. However, because under the universal health coverage, the National Primary Healthcare Development Agency is actually taking the lead. Prison health care is basically primary health care. And so if we can engage them, we can start doing something within the prison. Secondly, we already have the National Harm Reduction Program running. It's already on pilot stage. I'm a member of the technical working group. Though it's pilot in about 6 states now, that's something interesting and which I think we can leverage on, because I know that VIV, with support from Global Fund, is doing a kind of complementary project to states where we are implementing the harm reduction program, but basically for female drug users. And so such a thing can also be done in Nigeria, where you can do either, you can get funding to run, at least do a surveillance of the prevalence of hepatitis in the country. First and foremost, the prevalence of hepatitis C in the country, first and foremost, before we can now start planning. Because even if you look into our national strategic framework, though there's mention about key population, if you really go through it, there's nothing really that is directed to peer persons that are incarcerated or the incidence or prevalence of viral hepatitis C within the prisons.
Thank you. We're almost out of time for this first session, but I wanted to pick up on a question that was posted in the Q&A, and I encourage others to post as well regarding, I was going to turn it over to Luke regarding what tools or what materials are available to help deal with stigma within correctional systems, as I mentioned earlier, to Louisiana, either among staff or among the incarcerated persons themselves. So are there any tools in the Australia system that you would like to highlight?
Look, I think education is obviously the key to that situation, and we probably don't have enough. I've just been speaking to Andrew and others this week about improving our education for our staff. And when people join and we have primary training for our staff and they do receive information about bloodborne viruses and what they mean, I think fear is probably the biggest thing to address rather than stigma. Prison officers are very fearful for their own health. In our state, we had the world's first and the most publicised case of a prison officer who was stabbed with a blood-filled syringe, acquired HIV and died. We've named a jail after him and we celebrate his life every year. So the back of prisoners' minds all the time is the fear that they're going to be infected. So selling messages like the benefit of or the efficacy of a treatment as prevention approach and saying this sort of treatment is going to improve your health is a really good thing to tell, to make people aware of how treatable hepatitis C is. That's another really important function. So educating staff is the primary thing. The second thing, which we have used intermittently, but we need to come back with, is highly effective during the HIV period is peer education programs. We've done it in the past, and we're doing it again in pockets, but that needs to be probably more universal across the system. So involving peers are often the best people to send key messages to colleagues. But I think that the fear is the biggest thing to overcome, and having to reduce the visibility of treatment is another really effective thing, because prison officers don't like to be inconvenienced. So if you're having to take someone out to a hospital, for a public hospital, for a hospital escort to do a liver biopsy, those sorts of things are very inconvenient and cause big efforts on staff. But having a primary healthcare led model, like we have the nurse led model of care in our prisons, that's been really fantastic. Point of care testing and things that minimize disruption and inconvenience, and selling those points are also very useful.
Thank you, Luke. Those are all excellent points. We're going to turn it over to Nadine and Matthew in just a moment. But Andrew, do you have any parting thoughts before we depart?
No, let's move on, John. Thanks so much.
Okay. Well, very good. Thank you all to the panelists. A very rich discussion, a lot of key components there that we can take as lessons learned to help us improve HCV prevention and care in prisons. I'll turn it now over to Matthew and Nadine. Take it away.
Thanks so much, John and Andrew. And that was a great panel. And we have no doubt that the second panel will be just as enriching. Just to let you guys know, I am an assistant professor in the Department of Medicine and Infectious Diseases, clinician scientist based in Montreal, Canada. And Matt is a good friend of mine who is...
Hi, everyone. I'm an associate professor of medicine at Albert Einstein College of Medicine and Montefiore Medical Center in the US. And Nadine and I are both co-vice chairs of INHSU Prison.
We'll go to the next slide. And we have 6 incredible panelists. And as we did for the first panel, we'll ask each of our panelists, minus Anton's, who's already introduced himself, to introduce himself. So Joaquin, please go ahead.
Thank you, Nadine. My name is Joaquin Cabezas. I'm a gastroenterologist and a hepatologist who I'm working in Spain, in Santander, in the north of Spain. And I'm in charge of our viral hepatitis management, and also helping the prison that we are referencing in our region. And also involved in national plans for hepatitis elimination in my region, but also in Spain. Thank you, Nadine.
Thanks, Joaquin. Good to have you here.
Thank
Lee Christensen.
Oh, yeah, thank you. My name's Lee Christensen. I'm the National HIP Manager for the Hepatitis C Trust based in England. HIP programme, so that is essentially a high intensity test and treat programme. So we go into plan and deliver whole prison testing events right across the country. Been doing that for the Hepatitis C Trust since I started in 2019, and I've worked in the criminal justice system for the last 10 years. It's me, thank you.
Thanks, Lee. The HIT program has certainly inspired a lot of us around the world, so we look forward to hearing more from you. Sharon Hutchinson.
Good evening, everyone. I'm Sharon Hutchinson. I'm an epidemiologist that is based in Glasgow in Scotland, and I've been very much involved in developing the national data monitoring and surveillance programme on hepatitis C in Scotland to really inform our public health response. Thank you.
Fantastic, Sharon. This is certainly an area that requires a lot more work globally, so we look forward to hearing what you've been up to. Lise Lafferty.
Thanks. So I am a qualitative social health researcher working in infectious diseases in priority populations with a key focus on hepatitis C in prisons. So what that means is that I interview people who are incarcerated, correctional officers, the healthcare workforce, and administrators for the prison setting.
Thanks, Lise. You're one of the global qualitative experts in prison research, so we're super happy to have you join us. Julia Sheehan.
Thank you, Nadine. Hi, everyone. My name is Julia Sheehan, and I am National Women's Criminal Justice Manager for the Hepatitis C Trust. So I oversee a prison peer program across the 12 female prisons in England, supporting NHS England's elimination program.
Thanks so much, Julia. Julia's just joined INHSU Prisons in the last year, and certainly her work in female prisons is going to be enriching for our discussions in the next little bit. So we will move on now. Matt has the first couple of questions, so I will leave it to Matt.
Thanks, Nadine. So we've heard the first panel was amazing. It was amazing to hear those experiences from sort of the 30,000-foot view in policy. We're going to be diving more into the models of care. And I wanted to start with Lee, if you can tell us about key characteristics of opt-out testing at reception and the HIT model, just some of the nitty-gritty of what makes it work and how you got it off the ground in the UK. Lee, you may have to come off mute. Thanks so much.
Yeah, thanks very much. Yeah, so some of the characteristics, I think we sort of looked at prisons as an individual. Do you know what I mean? Each establishment by themselves, it's sort of the type of prison and the type of prisons that they were going to. I think for us, it was sort of trying to marry the initial reception and get reception testing ring fenced, and then come in alongside and work alongside our partners and key stakeholders in the prisons to deliver the HIT so that we could eliminate in the prisons. So part of the HIT process is to hold prison testing events to get test at least 95% of the prison. And again, it comes down to we sort of trying to inform a broad range of staff from the prison side and the healthcare side. We sort of put road shows on so people could identify what their role was in the bigger picture of elimination and try and gain that motivation for people, for it to be inclusive. And we sort of, it's amazing stats have come out, the amount of people we've done, and we've been lucky in that we have a prison peer model right across the English prisons. Do you know what I mean? That can work alongside and provide training to do that. So it's sort of, again, having dedicated staff working in reception works really well for us in some of the prisons. Understanding, having a good level of awareness around HIV, hepatitis C and hepatitis B, including all to be competent staff. I mean, looking at the different types of testing and if they work in the prisons and changing them from maybe a remand setting to a long-term prison setting where you've got more time and more time with the prisoners. It's gone in the sort of, and then to come in alongside to work with all the partners. And it's really some of the characteristics that work well is having consistent stakeholder engagement from all levels of staff. Do you know what I mean? So the communications going from the top to the bottom and then vice versa, including all. So we have a peer program. We also have a dedicated prisoner peer scheme that works alongside and can do some of the testings in some of the first night centres within the prison. Do you know what I mean? Dedicated staff and the peers really work alongside us. Do you know what I mean? So we have, and trying to create, we've also looked at the barriers to testing. So from initial screening to treatment, getting each, because each characteristic can work pro or against, depending on what prison it is. And you've added into this, so sort of cutting that down, getting each and working alongside each individual prison to identify what their barriers are. Change. Sometimes it can be as little as a language, using different languages with different prisoners and involving the peers in it and trying to gain that motivation to reach elimination and keep it.
Thanks, Lee. Thank you so much for that, the overview of HIT programs. I'm wondering if we can move on to Julia to talk about some of the nitty-gritty of peer programs. I know that's already come up in the previous panel about the role of peer programs for stigma reduction. But Julia, if you can follow up on Lee's overview of the HIT program, the role of peers in those programs, that'd be great.
So we have two types of peers. In the English prisons, we have the paid team of peers, which would support the prison pathways and support clinics and train volunteer peers within the prison. The volunteer peers' main role would be delivering awareness training, being points of contact for people who need support, and just raising awareness with lots of outreach. Any wellbeing events, they would support that. And the paid peers, we also, 80% of us have lived experience of both prison, drug using, and having had Hep C. So I think all of us can engage in a different way, in quite a non-authoritative way, because we're coming in as, you know, a separate entity from the prison. I think that we are quite unique in England in that we actually get access into the prison and get key access as well, because it would be really difficult for us to do that and manage. I mean, we have 150 active volunteer peers within the prison, and we need to manage them, deliver supervision, and we need to have access into the prison. So yeah.
Thank you so much, Julia, for the overview. Can you tell us about some really formative experiences you've had in working with either females or patients in general in the UK prison?
Yeah,
any stick out?
I think people in prison have trust issues. I was one of them, and sometimes, you know, coming into prison, you kind of you don't have much control over anything, but you do have that choice to say yes or no to a test. And, you know, people do say no. So that's kind of where myself and the volunteer peers, you know, come into play, where we can talk to people. We have the time to discuss and allay any fears. You know, we just want to support. I think, you know, my job will always be to find people to treat and support them to make the decision to accept a course of DAAs and get rid of it. So it's about empowering them to do that.
Thanks so much. And moving on to the first step of the cascade in terms of testing, maybe we can move on to Sharon and Joaquin about experiences you've had with testing. What are some of the models you've used in your settings? Maybe we can start with you, Sharon.
Sure.
What have been successful models for testing?
Sure. Well, I think the key is obviously having approaches that can facilitate rapid initiation onto therapy. It's essentially the fast tracking of the diagnosis and treatment upon entry to prison can increase your chances of completing treatment before the release, and that's essentially, I think, what you know, you need to develop your testing treatment pathway to kind of facilitate that. In Scotland, we've used dry blood spot testing for well over a decade in a range of settings, including prisons. That's really helped to facilitate a wider range of staff to undertake this test compared to with venipuncture. And the use of blood spot testing has been well received, but we can still encounter potential delays in the returning of results and getting individuals treated as quickly as you'd might wish to do. So certainly, you know, attention is turned to point of care testing, and certainly there's probably experience from other countries that we can draw upon that demonstrates that you get a high uptake of treatment with point of care testing compared to other more standard of care testing assays.
Thanks so much. For people who haven't had much experience with these models of testing, can you explain what the process is for dried blood spot testing compared to other point of care strategies?
Well, I'm not actually as familiar with the point of care testing. Perhaps I don't know if Jacqueline can come in on that one.
Sure, yeah. Joaquin, do you want to?
Yeah, regarding the treatment, first of all, you have to screen or at least test all the patients. And I think the best way to include these patients for treatment is to screen all of them at the early beginning of being admitted in prison in an opt-out manner. And that's the the best thing you have to do to eliminate hepatitis C in prison. And then the way we are working in Spain on a regular practice, this is like a blood run, and usually more than 90% of the hospitals perform the hepatitis C diagnosis with a reflex test. This means that you test first for antibodies, and then if this test is positive, the microbiologists automatically perform the RNA. So in a single blood test, you have all the diagnosis for an active infection. And I would like to go further, because if you have whole blood with a blood drawn, also it's important for this to test for other blood-borne viruses, so you can perform an integrated and a comprehensive diagnosis for these patients for hepatitis B, HIV, syphilis, and maybe tuberculosis, for example. And then regarding the treatment, fortunately, the treatment in prison was included in the beginning of our national plan for hepatitis C treatment. So they were treated regardless of the liver disease fibrosis. At the beginning of the DDA availability, there were some restrictions, but in prison, there was a specific statement where people living in prison could be treated regardless of the disease, the liver fibrosis. Now there is no restriction at all. And also Anton raised a nice issue regarding the funding. In Spain, the prison setting is funded by the Ministry of Interior Affairs, and then the healthcare for specialists depends on the Ministry of Health. So sometimes it's difficult to join both things. Fortunately, I think that having a national plan, a policy developed for hepatitis C globally, not only in prison, but also in the community, and join both efforts, makes things run smooth to get all people treated, at least in prison. And regarding the dry blood spot, I have also a few experiences, because in Spain, I don't know, all over the world, we have a specific correctional setting, which is called people serving non-sentences, norms, or student non-sentences that are not in prison, but also they are in a specific facility that belongs to the correctional setting, and they are free, but they have to check in this facility to serve their sentence. And in this place, it makes all the sense to carry out point of care testing. And also we carry out like reflex tests with point of care, a finger stick to test for antibodies, and those that tested positive, we run a specific hepatitis C gene expert to have the diagnosis in an hour time. And also the treatment could be delivered in this setting, which it makes all the sense, because you have to close the test and also the treatment in order to engage these people to be treated. And also in this settings, you have the global evaluation for hepatitis C, and you have to test for all the diseases. The dry blood test helps you maybe to rule out hepatitis B or HIV, that this kind of cartoons with these dry blood spots would help.
Thanks.
That's the experience. Thank you, Matt.
Thanks, Joaquin, and then Sharon, for that really rich information. Anton, so you had your hand up.
Yeah, I just wanted to add to Joaquin what he mentioned about the reflex testing. So just to say that it's also now has been recommended by WHO for laboratory-based or clinic-based. So if the whole blood is taken, that it can be used for reflex testing, so testing the same sample. In case of point of care testing, there is also another recommendation that point of care testing, both, I mean, the rapid tests for serology, but there is also point of care confirmation testing for using technologies, for example, like GeneXpert or some others. And it also can increase the linkage to care. And especially, I think in some countries, they are like more developed tuberculosis services, and they usually have those machines, especially if they were procured by the Global Fund. And these machines can be used for other infections, including hepatitis C. And there are some examples, some good practices where point of care confirmatory testing is used in harm reduction, but also can be used in prisons and really increase the linkage to care and put people on treatment faster. Thank you.
Thanks so much, Anton. So I was actually going to circle back and looking you have your hand up. In terms of the financing for GeneXpert and other point of care RNA testing, can you comment on what the process was like for that in Spain? Like, was it a heavy lift to get those types of diagnostics into correctional settings?
Yes, thank you, Matt. I think in the model of care, we were able to include this point of care testing. It was financed by a specific program, by a grant, having in mind that we could all transfer this model of care to our regular clinical practice. Unfortunately, the COVID pandemic hit this program, and this GeneXpert was moved to test for COVID, which was most important at that time. And at this time, this program is stopped. We were able to resume it, but usually the GeneXpert and also technologies that are for infectious disease comes from our microbiology labs. And unfortunately, I think 1/3 of the hospitals around Spain have them available for the community or in their setting, not only in prison. So I think in prison, the availability is fewer, because in Spain, most of the prison, they have their medical staff within the prison with nurses and physicians, so they are able to perform regular blood drawn and sent to the reference lab to carry out these reflex tests, and also the comprehensive diagnosis of blood-borne viruses. Maybe makes more sense, because the prison I'm in charge for patients it's like long stay prison, so time doesn't matter a lot at the beginning. But I think for those like that are serving non-custodial sentences, or that are like preemptives or something like that, the turnover is higher. The point of care testing should be the recommendation.
Absolutely. Lee, you had your hand up as well. Did you have a comment?
Yeah, I was sort of just game up what he just said around when we do a hit, we have our own expert that comes in with us to do that, to like try and shorten that pathway from point of care testing to treatment. Do you know what I mean? Because again, it's sort of a lot of our like initial demand when you had the high turnover of prisoners, you've got a chance to lose them. We sort of tend to use the point of care testing and the GeneXpert to try and shorten the pathway to get them onto treatment as soon as possible. Do you know what I mean? And mainly in the remand settings, because again, we've done some hits a bit like dry blood spot testing, but then it sort of comes down to the labs and how long the turnover is to get your results back from the labs and how many people you can lose that. So again, it comes down to the individual prisons and trying to create the shortest pathway from test to treatment.
Absolutely, and especially in remand settings. There's a shout out for peer interventions from Derek in the chat. So keep an eye out there, and please feel free to put questions in the Q&A, and I'll hand it over to Nadine to ask some questions.
Thanks, Matt. Before we move on, I just wanted to address Derek's shout out a little bit more. And that was, I was really interested with Julia's comment about the fact that there are paid peers and there are voluntary peers, and whether that's at all controversial to not pay peers despite their contributions in prison. So, you know, the current recommendation for WHO is that all peers should be compensated. And so curious to know if there's a movement towards paying those voluntary peers in the near future.
It's a great question, Nadine. I mean, I would love our peers to be paid, and there is a proportion that are, but they would be wearing like a Hep C peer hat and be a peer for maybe a healthcare peer or a substance misuse peer. So we would train them to wear a Hep C peer hat as well, so they would get paid. Peers that take part in hits get a bonus. We give Christmas bonus, but I would love them to be paid. I just don't think that we have a pot of cash to do that. I would love that.
I think we all would, and as someone who's starting a study in integrating peers and I've never done this before, I actually went to my Australian colleagues who have utilized peers just to get a sense of how much they should be paid. This is slightly divergent to our conversation, but certainly the range was anywhere between 25 and $45 an hour. So the compensation is relatively equivalent to, someone with, adequate level of education and training. So something to consider for all of us who are considering integrating peers in any of our models of cares and studies going forward. I'll start off, my first question is going to be directed to Lise. Lise, what type of training do you think is useful or helpful for prison healthcare staff to implement hepatitis C programs? I know Luke touched upon addressing fear and stigma, but I'm curious to hear what else you have to say on the matter.
I definitely agree with Luke about addressing fear and stigma through education, but I think it needs to be a whole of prison approach, so not just one particular group. One of the things that was touched on in the report by Chris Byrne and Tony McClure was the runners. In New South Wales, that would be the correctional officers who go and retrieve patients to bring them to the clinic, and that's a key point there, and that's where a lot of people in prison might say no because of that engagement experience. And we saw within the Stop C study that when officers went and retrieved people, they might use derogatory terms, or there's a real sense of shame and judgment that's happening there during that intervention. But correctional officers who were champions and understood the hepatitis C benefits, the treatment benefits for hep C for the whole of prison, not just people in prison, they were much more inviting and welcoming and keen to bring people forward to the clinic, and didn't see it as, an additional burden to their workload that they were having to do, and a begrudged experience, but contributing to the community. And not to use community in prison, that doesn't seem to align very well, but to benefit everyone.
That's great, Lise. And Lee, I know that you mentioned as well that there were several stakeholders involved before the HIT program became as successful as it has. I'm curious, was there any direct training that the individuals undertook prior to formally becoming part of the program?
Yeah, so we tend to deliver hepatitis awareness training to healthcare staff, prison officers, prison peers. Do you know what I mean? We've OMU'd as many staff as we can, to get that. So, because I think it's having that consistent approach when we're in there and we're delivering a HIT, you know what I mean? So if anyone's asked any questions, we have a frequently asked questions list, so everyone's given the same consistent message. You're not confusing any more issues, do you know what I mean? And again, the big part of that is our prison peers based on the landings, you know what I mean? So they be trained up weeks in advance, and we train them out to deliver their life story to peers, and they can incorporate 5 key questions within that around like treatment available to everyone, certain other aspects to that, to like make sure that like everyone's getting that same approach. Because I think the more staff, and we've had that where we sort of, when we're doing a HIT, we look for dedicated support staff for that time we're doing it, and you can see the more knowledge that they're picking up. And we come with that approach that like, we're not just doing this for prisoners, you know what I mean? We're trying to keep everyone safe, and that's all the staff in the prison environment too.
Yeah, that's perfect, Lee. I think the message there is really consistent messaging and making sure that everyone as part of the program delivers the same key message. That's fantastic. My next question, we talk a lot about decentralized care, but I'm curious, Joaquin and Anton's, Joaquin particularly as a specialist, do you think there's a role? Do you still think there's a role for specialists in prison, or can task shifting accomplish all the tasks that a specialist can undertake in prisons?
Thank you, Nadine, for the question. I must say that in Spain, the DDA treatment for hepatitis C is a high impact drug, so it must be prescribed and delivered from the hospital. That's because of the law, so I cannot do anything in this regard. But I think we have tons of experience. They are easy drugs to manage patients, at least patients that has non-complicated liver disease. And there are specific experiences that nurse-led prescription and management, or pharmacists or GPs, like ECHO project in the US, can deliver these treatments that are easy to manage for patients. So I think I'm completely sure. I still prescribe treatment for people living in prison because it is mandatory in Spain, that the communication and the lead in treatment management should be done by the people that are visiting the patients face to face, because it's at least for those, because I'm a specialist, for those that have a non-complicated liver disease, that are not decompensated, or they are not presented with an advanced liver disease, or maybe a co-infection that makes sense to be visited by infectious disease or something like that. But most of the patients that are we visiting, and if we increase the treatment, will be easy to treat patients. But
Great,
treatment must be done, sure, and screening, because at least in Spain, 1 in 4 patients usually present with an advanced disease, unfortunately. So it's much to do.
Thanks. So it sounds like apart from advanced cirrhosis, there's probably very little indication to having specialists in prison. Antons, do you agree?
Yeah, I fully agree actually with Joaquin. I think as more, if you test more, so if you test more people, then there will be a bigger proportion of patients with uncomplicated hepatitis C, which can be easily treated by non-specialists. And there's also one of the new recommendations in this new guidelines that the task shifting, and there is evidence that increases the access to treatment and completion of treatment if if the treatment is provided by non-specialist clinicians, but also even by trained nurses. But I think, of course, there is still a role of specialists because, as you mentioned, I mean, there are patients with cirrhosis or co-infection or with other problems. But I think in the prison settings, it's not very cost-effective to have a specialist all the time. But there are different models that they can be visiting once a month. Or there is also telemedicine options like the ECHO platform, which is used in many countries, where the attending physician can consult with the specialist. So yeah, I think that there are different approaches again. Over.
Fantastic. Let's move on to a topic that receives very little attention and even less research, and that is linkage to care. We know that over 50% of the incarcerated population serves very short sentences and are released before initiation of treatment or even completion. I'm curious, Julia, to hear what your experience is in linking patients to care, and if there's any models that the rest of the world can think to adopt that have had some success.
We have a Follow Me program, which started in the community, and we kind of nicked it for the prison setting, because what we came to see was that people were coming in for really short periods of time, getting released, and there was no real continuity of care. So what the Follow Me is we get consent from the patient to follow them on release and support them on release. Consent to liaise with probation services, where they pick up their OST and OATs. If they don't have an address, it might be where they beg, or if they sleep in a tent somewhere, we'll get where that is, and yeah, and we will follow them into the community. And I think I've got some stats here. So so far, since we started the Follow Me program, we've supported over 1,000 prisoners into the community, and vice versa, back into prison again, for those that come in for really short periods of time and are out for really short periods of time. and we've supported 600 treatment starts. So for me, that's just incredible. And I think as we edge closer to elimination, where people that are engaged in services and are quite engaging have been treated, and now the people that are left require more time, more support, and that's where we're really coming into our own through the gate work, where our community team comes and meets that patient before they get released. So they've like got a face to who's going to support them. They can be picked up at the gate. And yeah, it is for us to support them through their treatment, but it's so much more than that as well. And, you know, lots of our prisoners get released with nowhere to go. So we can support them with that. If they fall off their OAT prescription, we can support them to get back onto it. And the communication is key between community and prison. So if someone, for instance, may get released from prison and their medication doesn't go with them, which sometimes happens, they might be released from court, we can get that medication to them. And then vice versa, if they're in the community and they get recalled to prison and they turn up without their medication, we can get our community team to get it and drop it off. So yeah, it really is an incredible piece of work and ever more important as we near our elimination.
That's fantastic, Julia. I would love to see some cost effectiveness studies come out of your work, because these are resource intensive programs that, you know, clearly have worked in your model, but to convince policymakers that they are worth the effort, certainly that's an area that still requires some additional research. A couple of final questions. The next one will be on surveillance. Sharon, this one is for you. We've done probably, I think we all agree, globally a poor job of monitoring hepatitis C prevalence in prisons, focusing on the antibody, not RNA, focusing on prevalence rather than incidence. Very little work on reinfection. And so I'm curious, if any of us want to start a surveillance program, how do we get started, and what do you think the role is of surveillance for reinfection and transmission in prisons?
Okay, so I think you've kind of hit the nail on the head there, and I think is what Andrew presented earlier, that we got pretty scant data on progress on Hep C elimination within prison settings, even in a European context, let alone globally. So I think, you know, to really get us started on trying to improve our surveillance in prison settings, then we've got to kind of highlight the priority of this, and potentially even that, you know, maybe this comes not just at a national level, but a global level, in really recognizing the importance of us monitoring Hep C infection within the prison settings. We've got these global targets, which are now being adapted to focus on certain key risk groups, such as people who inject drugs. So it does beg the question, where at that global level, whether we need to have, I guess, greater focus on that, because I think it's really that will help support national, local efforts to, you know, get some coordinated effort on that, and get some increased funding to support all of that. And I think, you know, if you look at some of the work that's happened in settings like in Spain and in England, where you've got actually very good coverage of testing on admission to prison, that really does act almost like a surveillance initiative. We can actually generate really good data if we get very high uptake of testing at that point of entry, and obviously can need to follow through and look at the kind of diagnosis of an uptake of a treatment in those settings as well. And through that, you get a very good understanding of levels of infection in the prison setting, but also you get an understanding of what progress is being made out with prison settings in the community as well. You can kind of see, the impact of the scale up across all settings through even just monitoring within prison. And I think we need to tease that out more. Reinfection, I think you've touched upon, and that's certainly something that we've kind of been monitoring closely within Scotland. Again, utilising a lot of our administrative data, so we're kind of linking up records from all settings to understand uptake of testing following a successful treatment in a range of settings, and then looking at the extent of reinfection. And what you do find is people that are treated within prison settings do have a higher risk of reinfection. I think hits home that we really do need to promote testing in amongst those being treated in prisons, and other risk groups as well. But that will involve not just testing, routine testing in prisons, but it also involves scaled up testing in the community, which, because people will get released into the community, and therefore we need to follow up people in the community as well, not just in prison.
Thanks so much, Sharon, and to everyone. We're 1 minute over, and I wanted to just ask Lise to give us the final words. There was a comment earlier about the opportunity of hepatitis C screening and treatment in prisons. And Lise, I'm going to allow you to have the final words before we ask our attendees to complete their evaluation.
Thanks, Nadine. I think the question was raised around calling it the opportune time for testing. And I think that's a big issue of language that we often throw around in public health discourse around hepatitis C treatment, testing and treatment in prisons. And what we know is that people who are engaged and cycle in and out of prison, that often they can prefer healthcare engagement whilst incarcerated than in the community. This can be due to a myriad of reasons, such as competing priorities in the community. If they get released, they often have a whole range of things that they're trying to navigate through. Hep C certainly doesn't rank up there, as a lot of other healthcare needs don't get prioritized very often beyond perhaps opioid therapies. And then in prison, there's often the one-stop shop model of the clinic, and which makes it heaps easier for people to access healthcare whilst incarcerated than in the community if they're out on parole and adhering to a number of different expectations from the parole officer to be able to just go into prison. Once in prison, to be able to go forward to just go to the one GP, the one pathology, and not have to go buses across towns, it can be easier for people. Thanks.
Thanks, Lise. I'm going to pass it over back to John and Andrew to complete the session.
Thank you, Nadine. Thanks to everyone for a really robust discussion that we touched on a lot of points. Just a reminder quickly that this webinar will be available up on our website, as well as on the INHSU website at the links you see on your screen here. And that's a variety of other webinars that touch on aspects of HCV care as it relates to prisons. Next slide, please. As was noted earlier, we have a report that goes into more detail of the aspects of good programs that were touched upon here. So please, you can scan it on the QRS form or go to our website and download it. And I want to thank everyone for participating today, both as panelists and as participants in the audience, and look forward to working with you in the future to work together toward our mutual goal to eliminate hepatitis around the world. Thank you.
Thanks so much, everyone.
Thanks, everyone.
Thank you. Thank you, Andrew.
Thank you, guys.
Good on you, team. Thanks so much.
Thank you. Great job. Thank you.